REM behavior disorder is very different from somnambulism, also known as sleepwalking. Remember, sleepwalking episodes happen during non-REM. The eyes are open and the person is not dreaming, though they may be mentating. REM behavior disorder episodes occur during REM and with the eyes generally closed. It is the actual acting out of active, usually violent dreams. The sleeping person actually engages in complex, vigorous behaviors such as punching, kicking, grabbing, and leaping from the bed, often accompanied by loud vocalizations. As you can imagine, the sleep partner may be harmed. Usually the dreamer is experiencing fear and the behavior is defensive against a dream threat. Sufferers are generally pleasant, happily married, nonviolent persons. Onset can occur at any age, but it is more prominent in males, and the average age of onset is the early 60s. Sleep laboratory studies confirm that these episodes happen during REM sleep. Do you recall the two chemicals that are responsible for REM muscle paralysis? They are GABA and glycine. Yeah. It appears that REM-on cells, remember REM-on cells? It appears that they go awry in REM behavior disorder, causing depletion of these chemicals. Thus, muscle messages are intermittently blocked. For the majority of sufferers, REM behavior disorder appears to be an early sign of brain degeneration, such as Parkinson's disease or Alzheimer's disease, often with a 10-year lag, but in some cases, there is no associated psychopathy. The strong and clear association between REM behavior disorder and brain degeneration and the more recent discovery of these two chemicals is particularly exciting, as this knowledge may lead to advances in treatments and even possible future cures for these devastating neurodegenerative diseases. Insomnia is the persistent inability to get enough quality sleep despite adequate opportunity to do so. It results in excessive sleepiness during subsequent wake time. Insomnia has been likened to a fever in that it arises from any number of causes. Insomnia is the most common complaint and thus has been called the common cold of sleep. You can get advice for occasional insomnia as a disturbance if you desire, but to be diagnosed as having the disorder, it must be experienced persistently, in this case, meaning over a month. Consequences of excessive daytime sleepiness should sound familiar to you by now. They include irritation, depression, and hostility, concentration, memory, and judgment problems, and poor response time. It is mentally and emotionally distressing and can lead to grave consequences such as automobile accidents, interpersonal problems on the job, in school, in the family, and elsewhere. Anxiety and depression can build to suicidal thoughts and/or substance abuse. There are myriad types of insomnia. Some differences you can intuit by their name, such as sleep onset insomnia, sleep maintenance insomnia, and early awakening insomnia. Insomnias are also characterized by their causes, for instance, idiopathic insomnia. In the case of idiopathic insomnia, although poor sleep is confirmed through a polysomnography, extensive medical examinations and tests do not uncover any physical or psychological causes. A couple other examples of those characterized by their causes are comorbid insomnias, those that exist with medical or psychological disorders, and paradoxical insomnia. Paradoxical insomniacs claim to get little or no sleep, to think all night long, and that this mental effort is extremely fatiguing. However, their polysomnography appears normal. Their sleep problem causes them a lot of anxiety, but they seldom report daytime sleepiness. Interestingly, paradoxical insomniacs tend to respond well to treatment. Psychologists are split in that some believe it is a perception disorder that responds to treatment because of general placebo effects, while others suggest that parts of the brain, those that cause us to realize that we slept, might be dysfunctional in ways we are not yet able to measure. Further research on this interesting disorder should be illuminating. The best treatment for childhood forms of insomnia involve identifying and changing the situations that are causing it. Usually, these are dependencies on being rocked to sleep, nursed to sleep, etc., or a lack of setting and enforcing regular bedtimes. The best treatment for adult forms of insomnia are lifestyle changes, such as regular sleep schedules, avoidance of individual contributors, regular exercise during the first half of the day, etc. When these lifestyle changes are not achieved or do not have adequate effect, research has shown one form of therapy to be clearly superior to others for adult insomnia, that of CBT-I. Now, that's 3 capitals, CBT dash lowercase I, which stands for Cognitive Behavioral Treatment for Insomnia. CBTI begins with identifying sleep problems and contributors, including comorbid conditions, and the client maintaining a comprehensive sleep log, often with the help of a wrist tracking device. CBTI works like a jigsaw puzzle, as the identifications of contributors inform the log, and the log informs the identifications. With the identification of each individual contributor, the client can learn to avoid them. When they are difficult to avoid, the therapist and client come up with a counteracting activity. For instance, obsessive thinking can be counteracted with purposeful thoughts about a boring, non-engaging phenomenon. When enough interlocking pieces come to light, the big picture, and thus good sleep, emerges. CBTI. This concludes this course on sleep and dreaming. Congratulations on all your newly learned knowledge. I wish you all great performance on your last exam, a great remainder of your academic journey, and of course, meg wonderific sleep and dreams.